All right, so next topic we're going to talk about is the ins and outs of delivery. So strategically placed just before lunch. So we're going to talk about field delivery and complications of delivery and normal deliveries and so on. Usually pretty overlooked in people studying or kind of reviewing stuff. They don't happen that often. So we'll just kind of work through this one. But a couple of things to remember. The nice thing is 90% of these go fairly, normal without you. The problem we encounter is when these things go wrong, they can go horribly, horribly wrong with some major complications that we're going to talk about. So obviously it really comes down to it in the golden rule of EMS, which is no one dies or multiplies in the back of your ambulance. But if, obviously, we are dealing with something multiplying in the back of your ambulance, we're going to talk about some of the ways to help with this process or kind of treat the issues we're going along with. So the first thing we're going to do is we're going to work through the normal side of things. And then we're going to talk about complications. So first stage of labor, how many stages are there in total? 3? Couple. First stage is a regular contraction is when it starts, and it ends when the cervix is fully dilated. So the only way that EMS providers really have an idea you're in first stage is you're having regular contractions, but you don't have crowning, right? Because we don't check dilation of cervix and measure that. So really, we just know that if you aren't crowning, but you're having contractions, we're going to call you first stage. Second stage is once baby enters the birth canal, we're fully dilated, and we start to have this progression of childbirth. Third stage begins after baby is born and ends with the afterbirth of the placenta and things along those lines. So those are your 3 distinct stages, and kind of reminding yourself what stage we're in. First pregnancy, we can hang out in that first stage for up to 18 to 24 hours. So you might have some time. If we're into second stage, you're probably going to be delivering the baby on scene and then transporting. Hopefully, you're catching most of your patients in that first stage and get them to the hospital and get them taken care of. What are Braxton Hicks contractions? Like fake contractions. They call them practice contractions, right? They're irregular. They're nowhere near at the intensity level that regular contractions are. And so these are just the bodies of working on getting ready for regular contractions. Okay? Irregular, non-sustained. They're really not indicative of any sort of impending delivery. Moms can have Braxton Hicks contraction as early as 5 or 6 months, right? So this really has no indication that this is progressing until these start becoming regular. If you put your hand up on the uterus or the top of the uterus, which is called the fundus, you can actually feel those uterine contractions and things along those lines. What the doctor told my wife was if you can't talk through the contraction, that's a real contraction. Braxton Hicks usually are nowhere near as intense as regular contractions. 2 things we kind of forget when it comes to EMTs and delivering babies, because there's a lot to remember. And this seems like the first thing we forget is you need to be timing the contractions. And with timing, there's 2 pieces to that. One is the duration, and one is the frequency. Duration is measured from the start of one to the end of that one, right? Frequency is start of one to the start of the next one, right? So you're going to watch start of one, end of one. That's your length or duration. And then frequency is start of one to the start of the next one. Imminent delivery, so the ones you really, really don't want to see, is our contractions lasting 30 seconds to a minute, and they're they're 2 to 3 minutes apart, right? That really is an indication that you're more likely to start delivering, you're going to be delivering this baby on scene, right? That we really can't stop the progression of this. We're going to talk about what to do if the amniotic sac doesn't break on its own and it starts to deliver. We'll talk about that, but when it does break, or if it does break, really be aware that we need to ask about color and consistency and smell, because meconium staining is an indication of that. 1% of the time this can go horribly, horribly wrong. If there's meconium there, you're in that 1%, right? Aspiration, infection, breathing problems in the kid, all those things are really common in this meconium staining presentation. What does meconium look like? black tarry. It can be kind of greenish, right? It's thick, it's nasty, it's sticky. I'm pretty sure that you can put it in the back of a picture, hang it on your wall, and it will survive that wall no matter what happens. Fires, tornadoes, hurricanes. It is really, really
If
sticky
anybody's
stuff.
ever seen Vegemite,
No.
Australian peanut butter, it looks like used motor oil, and it's about the same consistency.
Gotcha. Thank you for allowing me never to try that.
I ate some this week in the UK. I ate some 5 days ago in the UK.
Yes, we had friends from Australia. I mean,
It's good. It tastes good.
It's really salty. It's their peanut butter. It comes out of the bottom of a beer cake.
Now you're getting closer to convincing me. You're working to the positive side now.
Yeah.
Start with the negative.
It's
and
the
come down on the beer cake.
leftover stuff from making beer.
Sign me up. I'll be a taste tester. Second stage, we talked about full dilation of the cervix. This is that, this really isn't like a sick or not sick presentation. This is more like, are we staying here or are we going to make the run to the hospital, right? Really, really think about it, because trust me, you would much rather deliver this baby in their home than you would in the back of your ambulance, right? Now, we prefer them in a hospital, but you just don't want to have to deliver this thing in the back of the ambulance. Okay? Through this whole process, once we decide we're going to deliver this at home or in the back of your ambulance, we're going to start working on care for baby, supporting their head. We're going to talk about no longer suctioning unless needed. That's really the big, big change in the new guidelines is stop suctioning infants that don't need suctioning. Why? Why not? We used to teach, right? What was the treatment or what was the process of this in your EMT class? Everybody. That, in fact, it was like the second you get a nose, suction. And then the mouth, suction again. Right? Why aren't we doing that anymore?
Taking away their air.
Taking away their air, right? It actually causes them to breathe less. It causes a vasovagal response, and it slows their heart rate down. Right? What happens if this kid comes out and he's got a mouthful of amniotic fluid, he takes a big old nice deep breath? Straight into his lungs. Is that a bad thing? What's been going in and out of his lungs for the last couple of months? Amniotic fluid. Right? Now, it might cause some complications, but it's not going to kill the baby for that exact reason. Right? Now, is there going to be blood? Yes. 500, 600, 700 mLs? Okay. Now, if there's a bunch of blood in the kid's airway, then suction. If there's meconium, suction. If there's not, forget it. It's not a priority anymore. Okay? After baby delivery, right, mom does all that hard work. All you did was catch, so don't celebrate, right? She delivered it, not you. You just caught. But after all that hard work, baby comes out, everyone's like, and then contractions start again, right? Body's got to give it a placenta. Now, this can take 10 to 20 minutes, as long as 30 minutes. Don't hang around, right? Transport mom, it'll deliver eventually. Under no circumstances ever assist the delivery of the placenta, right? Which is like, well, it's got this cord attached to it. Why don't we just pull it, right? What are some of the complications of that? Bleeding. Bleeding anyways. More bleeding. More.
You can leave pieces of it.
You can leave pieces of the side, and you could actually cause an inverted prolapsed uterus. It's anchored at the top of the uterus, and you can pull the uterus inside out and then prolapse the uterus. Okay, if you're like, what does that mean? It sounds bad, therefore it is. Right? Just put the uterus inside out and then pull it out. Stop it.
With the
Breech
same
delivery,
gloves
freaking
that
Jay's
you
gonna wrap a
use to
chain
clean
around his
up
ankles and be like, where does that go? Put it in the back of the ambulance. Tip her upside down, jump them down. Okay? Third stage, delivering the placenta. Okay, we're going to talk more about this, and I'm really going to gross you out here shortly. Patient assessment-wise, right? So let's work through, like, this is your number one priority, imminent delivery. We're going to deliver here, we're going to deliver in the back of your ambulance, you're trying to make it to the hospital. But what are some important questions? Is this your first kid, second kid, or Stevens County at 11?
You have any prenatal care?
Any prenatal care? Why do we care? Because who cares?
The doctor's able to kind of check to see if there's any positioning problems
Okay.
with the baby.
So if they say no to prenatal care, does that put them in that 1% population? It does. If they say this is their 11th kid, does that put them in that 1% population? Yeah. It just means it's going to go faster. It's like a slip and slide. There goes another one. Okay? What else?
Miscarriages, abortion.
Any miscarriage, spontaneous abortion, any procedures, things along those lines. What else? Drugs or alcohol. Does that put them in the 1%? Absolutely. What else? What other questions are important? You're forgetting one. Are you a twin? Right? Is there more than one baby? Right? Does that put them into the 1%?
Yeah.
And now it's an MCI. You need more help. Right? You're like, well, there you go. First pregnancy we talked about, how many babies? What about gravida versus par? Right? How many times have you been pregnant? How many times did you have live babies? Right? It's a good number to know. Have you seen a doctor? When did the labor pain start? Are you having the urge to currently push or move your bowels? Right? Again, are we on the imminent side of this or not? Now, examine for crowning. Most of us would agree this is not the most comfortable question to ask. Right? So what are some ways that you can ask this? What position do they belong in? What are some things you can do? First up, what position do they belong in? Supine. Adjust that a little bit. Maybe more like a semi-Fowler, because if they're laying flat, what happens to that 24-pound bowling ball? Compresses their vena cava, right? So on their butt sitting up, right? Knees bent, right? Cover them with a blanket and ask them to remove their pants and underwear. Don't do it yourself. Have them remove it. And then go, ma'am, the next time you have the urge to push, let me know. I'm going to lift the blanket and just see if you have crowning. They're going to go, what's crowning? If I can see baby, right? If I can see baby, we're not going to go anywhere. We're just going to go ahead and deliver it here. If you push and I don't see baby, we are going to do our very best to get you on a stretcher and get you headed toward the hospital. Okay? Uterine contractions. You can put your hand up there and feel for those contractions. Take vitals. Heart rate, blood pressure, glucose, SATs. All those things are going to be important. Okay? Rule of thumb. Baby's crowning, you're not leaving. Right? We're going to deliver this sucker right here. So, the findings that indicate that 1%, the bad news. No prenatal care, premature, so pre-36 weeks, labor induced by trauma. This is bad news. Multiple births. Okay? History of pregnancy problems like placenta previa or a breech presentation. Now the downfall is they haven't had any prenatal care, they wouldn't even know. Labor induced by drug use, especially the narcotics. Opioids, heroines, oxycodone, hydrocodone, all those things. Meconium stain. Okay? Make sense? We're going to go through a couple of those specifically when we get into the 1% here in just a second. Role of the EMT. Primary role, are you delivering here or are you trying to make it to the hospital? Okay? If you had to choose, it's the house. Okay? You don't want to do this bouncing down the road. Okay? Really, you don't want to do this anyways, but you might not have a choice. Okay? So, we decided we're going to go ahead and deliver this thing at home. So, start controlling your scene. What are some important things to do with your scene? What do you think?
Keep it warm, clean.
Keep it warm. Get it as clean as possible. Got to be sterile, right?
Try and afford mom some privacy.
Try to get mom some privacy, right? If it's like you're in a mall, right? Take some bystanders, have them circle around you, and then turn their back, right? You build yourself a wall. Makes sense? Because you got somebody with the cell phone, like, right? Let that slip out of his hand somehow. Whoops, sorry about your phone. And then I went to pick it up, and oh man, I stepped on it. I'm really sorry. Right? Call them, they'll buy you a new phone. What else you do? What about dad? They're helpful, right?
Not always.
No, never. I shouldn't say never. Not always. But dad, where does dad belong?
Waiting room.
Okay, Jay.
By the head of the wife.
when your kids were born, right? By the head of the wife. Now, if dad's a problem, where does dad belong? In the waiting room, right? Give him an instruction. Hey, here's the deal. It's really weird. I know it sounds weird to you, but I have to have 19 gallons of boiled water. So you go start, and when you got 19 gallons of boiled water, you can bring them back to me. Not until then. Bye. Right? Go give dad a task. Okay? Personal protective equipment. We're going to come back to that one. Place mom on the floor, the bed, or an ambulance stretcher. She doesn't belong on a coffee table. She doesn't belong on the kitchen table. She doesn't belong on a water bed. Okay? We talked about removing clothing obstructing the vagina for crowning. Position your assistant, who hopefully is a trained medical provider, and position your OB kit. Right? Rock, paper, scissors to see who has to catch. Hopefully you win. If at all possible, make your environment as warm as you can get it. Your environment should be at least 98.6 degrees. This is going to be miserable. Right? In a house, that's going to be difficult. The back of your ambulance, that's going to be difficult. In the backwoods, this is going to be impossible. Right? Start a fire in the tent. Right? And make it as warm as possible. What do you say? It's funny, I'm sure. So, BSI and Child Birth, right? Pretty easy, pretty straightforward. Where'd it go?
This we kind of covered it.
Oh, here. Bummer.
He's a little BSI student behind him.
Right? Like, what is your real BSI? Apron. Yeah. Goggles. Yeah. Mask. Gloves. Right? As sterile as possible. Think about that. Poor kid comes out with like no immune system. Zero. And you're introducing him to the most disgusting place he's been in. Or she. Right? All those germs. So be aware of that. OB kit. Now, this is a pretty stereotypical OB kit, right? Pretty generic, nothing crazy. What do you see as the most common object in there?
Well,
No, like what's lots of there? Like what is there lots of in this kit? Gauze, right? Gauze, more gauze, like gauze everywhere, right? Nasal aspirator, aka the booger sucker. Okay, pair of scissors, couple of cord clamps. Okay, a bag for the placenta. Okay, gloves, maybe a mask, right? What's this little thing right here? It's a little beanie. Yep. Because our kids lose lots of their heat from the top of their heads. Okay? And then tape for dad. Position for constant view of the vaginal opening, right? Since we're working through this process. Then, I love this, be prepared for your patient to experience discomfort. No kidding. Provide emotional support. You're doing a good job. Right? That's a good place. That's a good job for dad, mom, of the patient, somebody who's there, some random bystander who seems helpful, like they're just talking to them, tell them they're doing a good job. Okay? Communicate with your patient through contractions. Okay? Tell them, keep pushing, keep pushing, keep pushing, keep pushing, take a break. Right? You've got to communicate with them. Okay? Let's see here. Keeping someone at mom's head, that's always important. Now, as baby starts to come out, you're going to put your gloved hand at the vaginal opening, so that way when mom pushes, she's not pushing baby against no resistance. Without resistance, you can have what's called an explosive delivery that causes tearing and bleeding and all kinds of additional problems. Now, this hand that you're applying a little bit of back pressure is not like, no, we're not doing this, right? It's just a little bit of back pressure, right? You're not pushing it back inside, okay? That's me. I'm like, no, right? Tape your legs together, transport as fast as you can. Then, one hand below, baby, okay? And you're going to hang on. These kids are slippery. You want to know what this is like? Wear a pair of non-latex gloves. Grease up a pot-bellied pig and try to catch them, right? Don't drop babies. What's the rule of EMS? You drop a baby, you fake a seizure. Okay? Have a reason why you dropped them. Full on, pee yourself, convulsions, drool, a good seizure. Okay? Get you out every single time. If the amniotic sac has not been broken, you're going to break it. Take 2 hands. You can tear it. You can puncture it. It's not nearly as tough as you think. And what would happen is you would see crowning and you could actually still see the sac around baby. You're just going to break that sac for them. Okay? Do not use something sharp to break it. Right? You're not going to just take your pocket knife. That's what it's for. Okay? Once the head delivers, right? Nose comes out, mouth comes out, you get to the neck. Very first thing you're doing, take your fingers, run around the neck and make sure there's no cord. One of the more common complications is what they call a nuchal cord, a cord around the baby's neck. Now, not a big deal, right? Reach up, unwrap it off the kid's head, right? That way, as this progresses, it doesn't tighten, right? Reach down, unlock it. It might be 1 loop, it could be 2 loops, it could be a couple loops. Just pull loops so the neck's clear. Okay? Don't miss this piece. Really, really important. Then you're going to kind of help with the shoulders. Downwards is where you're going to go. You're going to kind of pull down. You're not pulling, you're just kind of assisting every single time mom pushes. Now the nice thing is, once the shoulders deliver, this goes pretty quick. Shoulders are pretty wide, widest part of baby. Now, once it gets shoulders out, baby's going to come out and probably a push or 2. Okay? Make sure you support the entire process. The only time, or we're going to talk about, I guess it's the next slide, or next couple slides, about sectioning. Exact time of birth. What time are they born? Okay? This is kind of working through it. So this is support baby's head, a little bit of back pressure. Okay? Now, upper shoulder is going to come out. Baby's going to kind of rotate, suction if needed, support the trunk. A real good position is dropping that arm between their fingers, getting a good hold on the thing. Because again, right here, probably a push, maybe a few seconds, and baby's going to come out. Okay? Look how cute it is. Support the pelvis, lower extremities, out it comes. No big deal. Questions? That's delivery. Now, what are some priorities when we're assessing or treating the baby itself? Skin color. Skin color.
They're crying.
They're breathing.
They're crying.
They're crying or not crying. What score are we using? The ABCAR score. And we take it at what 2 intervals?
1 minute.
You're close. 1 minute and 5 minutes. Right? ABCAR should improve in that 5 minutes. It's really common for the ABCAR score to be less than normal at 1 minute. Cyanotic extremities is really common. A weak cry is fairly common. We hope at 5 minutes we've improved that good score of 10. Okay? So, we're going to talk about ABCAR here. Appearance, pulse, grimace, activity, and respiratory effort. This is the score. Right? You can get a 0 in ABCAR. Okay? Obviously, a cardiac arrest baby would be a 0 on the ABCAR score. And then document the other ones throughout this process. Okay? Again, 1 minute and 5 minutes. Now, I don't like this picture because I think it does a really poor job of relaying the point they're trying to make. The point they're trying to make is you may have to stimulate baby to breathe, right? Which was the idea back in the day when they used to spank the newborn, right? Like the very first thing it's in this world that gets assaulted. Like it's a really poor way to start life, right? Some of you may need it, but that's all right. Okay, this right here is not pissing them off. If you're going to use stimulus like drying them or rubbing them, take a blanket and vigorously rub their back. Piss them off to the point they're going to breathe. Because crying babies are breathing babies. Okay? Babies should not cry. They just went through a fairly traumatic experience. They literally were smashed for the last however long. Right? Compressed into this little thing and then shoved out into the world. They should be fairly pissed off. It's very cold. 98.6 degrees to 70 almost instantly. Okay? One of your very, very high priorities, keep them warm. Okay? Dry them. If the blanket's wet because of the mucus or the blood or whatever, get rid of it. Use a new blanket. Every single time the blanket gets wet, get a dry one. Okay? Then you're going to wrap the baby in a completely dry blanket. Dry them off, wrap them up, swaddle them, right? And then where does baby go? On mom, right? Now, let's say you're having a hard time with blankets, getting them warm. Where could you put baby? On mom, skin-to-skin contact, right? Helps with bonding, helps with soothing, helps with antibodies, helps with hormone release, helps with all kinds of stuff, okay? Don't forget to cover the watermelon, right? Their head. Big old heads. Cutting the cord. Is it really a high priority?
No.
No, not anymore. Before it was like that was the most important thing we taught EMTs. Don't forget to cut the cord. You won't forget, it attaches baby to mom. You can't really go that far. Okay? So you clamp again, and you cut in the middle. Now, let's say we're in that 99% of deliveries where this has gone perfectly fine. The only not fine thing is you were there, right? Could dad cut the cord?
Yes.
Sure. Don't be afraid to ask. Hey, great job. You're doing awesome. Dad, parent, whoever, you want to cut the cord, right? Now, I've met providers who are like, wait a second, I just delivered the baby. I want to cut the cord. That's not your freaking job, right? Now, if there's a complication, sure. Don't bring dad down and now understands like baby's now, there's issues or whatever. But if we're in that 99%, let him cut the cord. Ask. No big deal. Okay? This talks about apply one clamp about 10 inches from the baby, place a second clamp about 3 inches from the baby, and then you're going to cut between the two of them. Okay? It's much tougher than you think. Right? I've cut both of mine, and I thought it was like tissue. It's like a boat rope. Like, it's really, really tough. It's a vein and an artery, and the doctor's like, cut harder. I was like, dude, my wife's attached to one, and I'm asking, what if I hurt him? I was like, you're the dumbest person I've literally ever met. Exactly. What a confidence there. Okay? Pretty easy. Warmth, airway, we'll talk about. So here's a couple of numbers. This one right here. It's the same slide, just a couple different things. First off, here's the first number. If your baby, not your baby, their baby, if their heart rate is below 100, you're going to breathe for them at 40 to 60 breaths per minute. That's not a mistake. If their heart rate is less than 100, you bag them. If their heart rate's less than 60, you start CPR. Okay? A normal heart rate for you does not work for the neonate. It's not fast enough. Okay? 1/3 the chest diameter. Encircling thumbs is okay. Your ratio, this one a lot of people miss. Your ratio for neonates is 3 to 1. 3 chest compressions, 1 breath. 3 chest compressions, 1 breath. It's not 15 and 2 or 30 and 2. It's 3 and 1. Okay? Pulse check, stethoscope, brachial pulse, cord stump, all those places are good places to check for a pulse. Usually the anatomy is so underdeveloped that brachial pulse works really, really well. Okay? Neonatal resuscitation. This is why people say that delivering babies is an EMT's job. Because if you think about it, everything we're going to do for them pretty much we can do. It's really, really unique. The downfall, I think, with PALS, Pediatric Advanced Life Support, paramedics take it and they don't have any pediatric calls. So they don't use it, so they have a hard time remembering some of those guidelines. Right? The one thing that will probably save your butt is a Broslow tape. Right? Utilize the Broslow tape. Lay it out. How big are they? How tall are they? Those kinds of things. And then start looking at normals and, if medics are given drugs and innovation and those kinds of things. We talked about chest compressions, 1/3, the half of the chest. Very small infant, thumbs may overlap, that's okay. So let's talk about care after delivery. First thing, let's talk about caring for mom. Okay? So one of the things mom's at risk for is pulmonary embolisms. All those clots that are starting to form, God forbid they start circulating to her lungs. Okay, so be aware of that. The next one is, don't forget, you just created a 2-patient scenario. So now you're working on mom while trying to work on baby. So split your team up if needed. Okay? Then comes the placental delivery. We're going to talk about controlling vaginal bleeding here in a second and providing comfort to mom and to family. So, delivery of placenta, it could take up to 30 minutes. Now, it says begin transport in about 20 minutes. It will probably take you about that long to get everyone packaged up, everything good to go, and then let's get down the road. Especially this is a non-critical, right? We're in that 99% of the time, no big deal. Okay? What do we do with the placenta once it delivers? Keep it like yourself, or what's it for? It's for the hospital to take a look at, right? So we put it in a bag, we take it with us, right? There are certain populations and belief systems that still eat the placenta of their children, right? Now, my dad originally taught this presentation, and he found these. I was like, what are you Googling? I love this. Just has placenta on the top of that was box. That's killer. Recipes, placental pizza. That's not really a soup I think I would try. I'm a big soup fan, but not a placental soup fan. Okay?
Well, I was talking about what it looks like inside.
Oh, yeah. I'll show you a picture.
Oh, no, I've seen it.
Okay. I don't want to say it anymore. Controlling bleeding. Couple of things you can do. One, right? We can elevate the feet a little bit. Put mom's legs in there. Put a sanitary napkin in the vaginal opening. Two, we can massage the fundus or massage the uterus. 2 hands, vigorously massaging. Kind of a hard massage. You're trying to stimulate that uterus to start shrinking. Third, and it's really, really overlooked, is have mom encouraged to breastfeed. It stimulates hormones. It helps with stopping bleeding. Now, what if mom says, I'm not going to breastfeed? That's okay. As this progresses and you still can't stop bleeding, be like, listen, I know you don't want to breastfeed. You don't have to continue, but we're losing this battle here, right? Do skin-to-skin contact if nothing else, okay? That was with baby and mom, not. We talked about placing a sanitary napkin, have mom lower legs, massage the uterus, encourage mom to breastfeed. Providing comfort to mom. Acts of kindness will be appreciated. Okay? Don't transport mom in the bloody blankets and sheets and those kind of things. Clean her up, right? Cover her up, right? Do those, wipe her face off, do your very best to make her as presentable as possible. She's probably going to see a lot of people in her near future, right? So kind of be aware of that. And then as things slow down, I would ask mom, especially if you're still at the house or whatever, hey, let me know if you want to see people. Can we start looking back in? Don't be like, oh, David's born, let me see him. Time out. Mom or dad's choice, right? Don't just assume, all right, all done. The little wall you built, be like, all right, you guys are good, go away, right? Hang out for a little bit and kind of help mom out. So let's talk about childbirth complications, okay? So 1% of the time, this can go wrong, okay? Have we ever not seen this movie? Okay, good. Just making sure that everybody gets the reference in. Common complications. So of the 1%, here's the common ones. Cord around the neck, unbroken amniotic sac, and infants who need encouragement to breathe. I'm okay with those 3. I can fix the top one. I can fix the second one. I'm really good at fixing the third one. So if you're going to have complications, these are the ones you want to have. Okay? Now, here's the not common, but really, really bad circumstances. Breech presentation. Okay? Here's the downfall. Of the abnormal deliveries, this is the most common type. Okay? We're talking legs first or butt first, almost like a pipe position, right? Legs up by their head, and they're coming out butt first. Babies are not meant to come out this way. The nice thing, prenatal care, they do an ultrasound and go, that's not good. Let's get you in for a C-section, right? There are some doctors who still attempt a manual rotation of baby. Not very comfortable for mom, has some complications. Depends on if the OB believes in that or is a fan of that or if mom consents that or whatever. Okay? So breech presentations are not to deliver in the field. Okay? In fact, they shouldn't deliver vaginally. Okay? Limb presentation. 1 foot out, 1 arm out. Checking the temperature. He's like, oh, it's cold. I'm staying inside. Right? Not coming out. What about this one? Can they deliver in the field? Not usually. Depends on the actual position of baby, but feet first, not a good thing. Umbilical cord present first. We call this the prolapsed cord. Now, here's a couple of problems. One, cord comes out first. It gets cold. It dries out. And it gets compressed, whether it's by the vaginal wall or by baby's head, or both. Right? So what's the treatment for this? Wrap the cord. What else? One more treatment. You probably learned in your class. Really uncomfortable. Nope, not when you're close. Kind of guided. Baby. 2 fingers go inside the vaginal opening, and you take the pressure off the cord. You don't want it compressing the cord to the point where it's inhibiting blood flow. Right? Now, for prolapsed cords, what position does mom belong in?
Head down, lower body.
Yep, head down, butt up in the air. Especially with a breech. A breech, you want her flipped over, and you want her butt up in the air to have gravity actually help not deliver this baby. Okay? Now, let's say baby starts to deliver, right? You got to put your hand, right? Because what will happen is they'll deliver backwards up until about shoulders, right? Both their arms go above their head and they lock right there. They're stuck, right? So what you do is you take your hand and you run inside mom and you run your 2 fingers up alongside baby's face. And you put your fingers right under their cheekbones and you provide them a breathing area. Because again, those tissues are compressing. And then guess what? You're stuck there. You're going to roll in the ER attached. And you get to go to the OB room because you can't let go. Okay? Multiple births, have adequate resources. Add an extra ambulance. Okay? Clamp or tie the cord of first baby, assist with delivery of baby the second time. Just know, it's a really good thing to know. A buddy of mine had a delivery a couple years ago on the back of the ambulance, delivered the first baby, was like, hey, this is awesome. Mom said, oh, by the way. He was like, son of a... All right, well, let's do this again. Okay? Keep baby warm, keep airway clear. The premature side, again, the encouragement to breathe, probably likely. Especially, I can't remember what the actual gestation is, but I think it's like 35 or 36 weeks. Before that, they won't have the ability to breathe on their own. Their alveoli aren't developed by the way. More likely to be a NICU or something along those lines. So understand that before 36 weeks, they might have some pretty severe respiratory complications. So be aware to assist them and work with them. Okay? Meconium. Again, pay really, really close attention to the color that baby is and the color of that fluid. If you have meconium section. Okay? And then emergencies in pregnancy, placenta previa. What is it?
There's a way.
What's that?
There's a way from the wall.
You're close.
No placenta delivery for the baby.
Yeah, placenta is anchored at the bottom instead of the top. So the left picture is normal. Right picture is placenta previa. Now, one of the things that they're checking for in the very first ultrasound, weeks into this, is where's the placenta. So they know very early on where that placenta is. Now, Jay, what you're talking about is the placental abruption, which is the premature separation of the placenta from the wall. Now, here's what here's them side by side. Placenta previa is painless bleeding. It causes bleeding, but there's no pain associated with it. Placental abruption is tearing, therefore they have bleeding that is causing pain as well. Okay? Usually complaining of a tearing or a shearing pain in their abdomen or down lower where their uterus is sitting. Excessive pre-birth bleeding, get them transported. High concentration oxygen if needed, treat for shock. Ask questions, how far along are you? Don't make any assumptions about losing baby, saving baby, conflict, none of that crap. Just leave it out of your assessment questions. Okay? Ectopic pregnancy. Is this lethal? Can be. Right? Does this kill all fetuses? Yes. It has a high rate of killing mom. Here's the rule of thumb. Women of childbearing age presenting with abdominal pain in the lower regions, this is number one in your differential diagnosis, no matter what. Right? Now, you could ask a question. Any chance you could be pregnant? A better question is what? Because that question is, nope, no chance. Especially when dad's there. What's a better question? Maybe menstrual cycle, but can you have a period and still be pregnant? You can't. So could you say, are you sexually active? Again, they could still lie in front of dad and say no, but it's interesting, you're more likely in privacy to get a yes to are you sexually active than you are is there any chance you could be pregnant? And the answer's like, no. Well, guess what? If you're sexually active, there's a chance. Right? 10 years. I've never had a patient answer any chance you could be pregnant as the answer yes. And I've transported numerous people who get to the hospital, the doctor goes, you're pregnant. They go, but there's no chance. Stop. We've heard it before. Right? So are you sexually active is a good alternative to any chance you could be pregnant. Seizures. Usually we're talking about our preeclamptic patients. Right? Elevated blood pressure, excessive weight gain. They present an awful lot like CHF, pedal edema, facial edema, hand edema. And we're talking about weight gain of like 5, 10, 12, 15 pounds in a week in water weight. These patients almost always become high risk and they get put on bed rest. Right? Miscarriage and abortion. Now, me and the textbook don't agree. They talk about spontaneous abortion. And spontaneous abortion is the medical term alternative to miscarriage. The downfall is you say, have you ever had a spontaneous abortion? What's the one word they hear? Abortion. So I'm a bigger fan of miscarriage than I am of saying spontaneous abortion. Trauma. Now, the downfall is their heart rate's already faster, their respiratory rate's already faster, and they have more blood volume. So here's the downfall. They compensate better than anybody else. They hide the signs and symptoms of shock longer because they have extra mLs of blood because they're pregnant. So be aggressive. Okay? Because something like a ruptured uterus can occur in trauma. This could be a blunt force trauma. This could be a seatbelt. This could be an assault. And this is where the uterus actually ruptures and baby comes out of the uterus. Okay? This is extremely lethal on both sides, baby and mom. Okay? Lots and lots of bleeding. All that amniotic fluid, everything starts coming out. Okay? A lot of the MOI of this is wearing mom wearing her seatbelt up at her belly button when she wrecks her car. Right? 8 months pregnant, seatbelt's up there and cinches down and rips that uterus right open. Right? That seatbelt belongs down in her pelvis where it was always intended, where you wear it all the time, except for now you've got that beach ball on your stomach, so you think it's going to go up on her belly. Okay? Stillbirths. If there's any question, resuscitate. If it's obvious baby's died long before, it's decomposing, it's got blisters, it's odd colors, it has a foul smell, you don't have to start resuscitation. If you have any question whatsoever, start it. Questions? Let me stop this real quick.